So moving on to indomethacin. For the indomethacin, the dosage available is from like 25 mg, 50 mg, and 75 mg available in the market, right? And still, you can just focus more on these two, 25 to about 50 milligrams, and you can give somewhere about 8 to 12 hourly. Okay, so it roughly around like max dose somewhere about like 200 milligrams per day. Still, you can give in one day before hitting the toxic dose, right? So onset of action, ONSET, onset of action is again 30 to about 60 minutes. It can again vary in person to person. Overall peak timing, the peak time where it will show its maximum effect will be somewhere around 1 to 2 hours. The duration of action, it will work somewhere for about 4 to 8 hours in person to person, right? Now let's talk about the most important thing, the GI risk for the bleeding. So let's switch to our table first, right? So this was our table. We are over here on the indomethacin. Indomethacin has a good coverage for analgesic, moderate for the fever, and good coverage for the indomethacin for the anti-inflammatory effect. However, it still have the power, good power to cause the gastric bleeding. So yeah, and for the side effects, it was much more CNS toxic, which can lead to several other complications as well, right? So not that commonly used, but because of the duration of action, it can still from like 4 to 8 hours. It has a good coverage for analgesia, pyrian, and other stuff, right? So for the GI risk of bleeding, it ranges somewhere from about like 100 mg per day. More than about 100 mg per day, if you go like this, you will be at a greater risk to cause a GI bleed, but still you can go up to like 200 milligrams per day before hitting a severe side effect of indomethacin, right? Now for the indications. Indication. Now indication of indomethacin is very, very important, right? Indomethacin can be, because it has a good analgesic coverage, you can use for again gout, arthritis, you can use it for pain, right? Ankylosing spondylitis, right? Let's see the T table again. So the indomethacin was having very, very nice anti-inflammatory as well as a very good analgesic effect, right? So because of this very good, it was a very good analgesic as well as having the anti-inflammatory property. And because of all these two things, there is a pain and inflammation are seen in all these conditions. Indomethacin is a good drug in all these conditions, right? Also, we can use indomethacin for the PDA closure. So in the fetal life, we know that there is a PDA which keep the ducts open, right? So in order to have the mixing of the blood. However, after the fetal life, we need to close this patent ductus arteriosus. Usually it happens spontaneously by its own. Now PDA actually is open in the fetal life by the help of prostaglandins, right? When we were talking about the prostaglandin, right, we discussed about this, right, that whenever we give the prostaglandin, it will keep the PDA open, right? Prostaglandin will keep it open. So we need to shut down this release of prostaglandin to make it close, right? Shut the prostaglandin and the PDA will close. PDA. And for this action, indomethacin is a very, very good drug, right? Technically, all the NSAIDs, right, can be used to cause the PDA closure. this is only technically but not on a ground level, because all the other drug will have a very higher other risk that you don't want in either the infant or to the mother. So indomethacin is that drug that will help us to close the PDA effectively, right? So out of all 15 drugs, all important 15 drugs, only the 3 are still much more effective and kind of safer, can be administered to the fetus, right? These include, first is the indomethacin. The second is the ibuprofen, and lastly the paracetamol. We start with the indomethacin and then we just move through some other letter. The indomethacin is really very helpful, right? You can see the effect directly onto the indomethacin. If not, you can move to some other drug, it will also act the same. However, the difference that we don't use other drugs is solely that because of the other side effects and other things, right, that we need to keep in mind. Also, the duration of action, onset of action make it the suitable candidate for the user of PDA. So PDA, important stuff, right? And because still it has a higher risk, right? Because the GI bleeding will start somewhere about like more than about 100 milligrams per day, but you can go up to like 200 milligram per day. But so the risk of GI bleed will be again high. And the table also, the indomethacin, right, was having a higher level because the GI bleed, not very high, but still higher than the other NSAIDs. So for this we give PPIs, right? So for for the ketorolac, right? For the ketorolac, there is a very important NSAID that we can use along with it. That is the dexlansoprazole. Again, how we choose drugs, how we choose the PPI will depends upon various things. How much faster the NSAID is working and for how longer the duration. I guess I've already talked about how to choose a PPI, right? We choose PPI on 2 different bases. It doesn't matter which type of NSAID you are choosing. We choose PPI compared to the NSAID used, right? So overall duration of action and how much potent. You can also add one more: how fast is onset of action. So 3 things: potency of PPI, dose of duration of action of NSAID, and how fast the onset of action of NSAID. So this was for the ketorolac, right? I just forgot to mention in the previous lecture. Anyways, you can use the dexlansoprazole and you can go up to like 30 mg once a day. Dexlansoprazole is very potent. Why? Because the ketorolac itself was very good analgesic, and because of this there was a higher chance of occurrence of GI bleed, right? Coming back to the indomethacin. For the indomethacin, we again use PPI, which is none other than the omeprazole. For the indomethacin, the PPI that we can use is omeprazole. How much? You can use about 40 mg OD. After completing the NSAID part, we will quickly talk about the PPIs, what PPI do, what the function, and so, and how to choose particular PPI for the given NSAID. So this was about the indomethacin. Did I just forget anything? We completed dose, onset, and so, indication done. It is a very good analgesic, inflammatory, PDA done. NSAID is for the PDA closure. Okay, so this thing is theoretically you can. However, if we are using other drugs, none other than these 3, there will be higher risk of other complications that we don't want in either the fetus or to the mother. So most safest, right? Let's write it over here. So this is actually the safest version, okay, for the PDA that we can use to close, right? Indomethacin, ibuprofen, and the paracetamol. And how they make all this thing? Because of their features, right? Indomethacin is seen as toxic beyond the limit, right? The ibuprofen is again nephrotoxic, again beyond the limit. Aspirin and other stuffs we can use, but their range is so much narrow to cause the toxicity. So why to use all those drugs when you have a better option available? So this was about the indomethacin.